This is the Neurosurgery Podcast.
Welcome back to the Neurosurgery Podcast. I think today we again tip our hand. JP and I reflect our spine orientation and bias in neurosurgery. We are welcoming for the first time to our show Professor Claudius Thomé. I've known Claudius for, oh my God, over a decade. He is a fixture in Europe. He is one of the great professors of neurospine surgery in Europe. He's in Innsbruck in Austria. We've had the opportunity to have trainees go back and forth between Miami and Austria. He is a true spine master. Claudius, welcome to the show.
Thanks so much. Great. Glad to be here.
Yeah, so we do have occasionally continental Europeans on, but it is a different system than the U.S. So maybe introduce our listeners to who you are, where you're from, how you trained, and all that.
Yeah, I'm very happy to. Thanks, Mike, for having me. No, basically, my name is Claudius Thomé. I'm a neurosurgeon trained in Germany, and then went to the States for a couple of fellowships. Spent quite some time with Jürgen Harms, an orthopedic surgeon at the time, close to where I was trained originally, and have a special interest, obviously, in spine, but in Europe, particularly if you are German and full professor, you tend to be still doing general neurosurgery. And then now, 16 years ago, I moved to Austria and was lucky enough to become chairman here in Innsbruck in the center of the Alps. And as I said, glad to be in this podcast.
Well, thank you so much for joining us. And before we do a deeper dive into your current practice and neurosurgery in Austria versus America, which I really want to get into, let's talk a bit about how you and I met a couple weeks ago. I mentioned on the show in a recent episode, I had the privilege to go to an EANS, the European Association of Neurosurgical Societies, I think that's right, course in spine surgery for a week in Sofia. And what a phenomenal experience. Every time we have a guest on, I'll say thank you very much to the EANS and the American, the AANS, who sponsored me going with one other American resident. But I know that you have been instrumental in these courses over the years, and you're frequently voted the best instructor. So take a moment and plug the course for the other North American residents like myself who may get a chance to apply and come attend this incredible resource.
Yeah, well, this is the basically the core of the ENS for many years, and this has been a course going on for decades. And now it's a 4-year program, and about half of European neurosurgeons, neurosurgery residents, passed through it. So we have
Wow.
tumor, spine, vascular, and trauma and functional, and obviously the smaller areas as well included. And it's the true spirit of the ENS, because it's not only about teaching; it's very much also about networking, getting to know people, getting linked with others. And we are very glad to have the Americans on, because they always have a little different input, which is great, and
Especially at the spine course.
no. Oh, at some of the courses actually, but we like it. That's the beauty. This is something that you guys probably can't even appreciate, that in Europe, with 30 plus countries involved in that course, it's so different from, let's say, southeastern Europe to northern Europe to western Europe. And this is actually a beauty of it, that this diversity, to learn how things can be done differently or with less resources or whatever.
Yeah, it's so fascinating to me. I mean, I think shout out to some of the other former EAS presidents like Carl Schaller, other friends in Europe we've had on the show like Enrico Tessitore and Bernhard Meyer, of course, from Munich. They're all your good friends, I'm sure.
Absolutely.
I want to jump right into some of the differences Europe and America. And I think, for a lot of our listeners are from outside the US, not even from Europe or America, Asia, Middle East, Latin America. And, the diversity of the world of neurosurgery is something we probably don't talk enough about because we're so North American focused, right? Canada, US. One of the things that struck me, I was with Bryce, I always say his name wrong, Ilherold from Bordeaux. He's a very famous orthopedic surgeon, does a lot of spinal deformity. And we were commiserating about how a lot of the big companies are pulling out of countries. Like I heard DePuy is pulling out of France, right? And so, what is going on in Europe? Because in America, it's capitalism. It's all about do more surgery, do more advanced surgery, use enabling tech like robots and AI, and then what's the newest implant and fixation or motion preservation. And I know Europe is very forward thinking in a lot of these realms, but what is happening to the spine industry there locally?
Well, that's actually a difficult topic because obviously the governments are trying to cut down costs tremendously, and particularly in countries like France, they just say you can only charge a couple of hundred, maybe not even less, dollars per screw or something, and the implants have to be super cheap. They kind of rule that, and that's why it may not be profitable enough for some companies to really stay in the business. And since most of our countries have a socialized medicine system, the incentives are quite different. I always wonder what potentially is the best system. To be honest, I like the system we have in Austria. It's socialized medicine in a way that everybody is insured, and healthcare is actually very good in our country. But obviously, the salaries for doctors are quite limited. The salaries for all health personnel is quite limited. Also, the earnings for the companies are at least not capped,
Mm.
but at least somewhat controlled in a way. And so it's a very different scenario. Trying to limit costs and trying to give healthcare to everybody.
The other thing that we frequently talk about when we're able to have guests on from other countries anywhere in the world, and something that I was gossiping and complaining about with all the European residents for that week in Sofia, was the difference in training structure between America and different European countries, and in particular, the work hour restrictions, which we also have in the States now, but even our restricted hours tend to be much higher than the number of hours that people can work in different countries around Europe. We've had a few guests before. Peter Vykotsky's been on the show talking about evolution and training over the years. Patrick Grover in the UK when there was a resident strike. So maybe talk a little bit about trends that you've seen over the course of your career, both over time in the restrictions around how long and how hard residents can work, but also regional differences in different nations around Europe.
Yeah. No, that's one of the biggest problems we have. That on the one hand, we have working hour restrictions. Some countries, residents only work like 40 hours. In some countries, they are allowed to work a little more, 48, or opt out somewhere about 50, which is obviously very different to our times when we were working in residence in the United States, 100 hours or at least 80, 90 or whatever. And the problem is that because of that, we need much more residents to cover calls and to be there for assisting surgeries. And as a result, of course, they have much less exposure to cases because they have to share them in between a much larger quantity of trainees. This is very different from country to country. Also, how training is performed. Some countries have a very structured training. Some European countries not that structured. There's um, not that good exposure to surgeries in some of the countries, and they tend to even learn surgery once they are board certified, which is a nightmare, if you will. So this is a big problem. We are hoping that the new educational tools like simulation, etc., will make this better. Also, legal issues have been a little problem, even though not comparable to the states. But this is a true problem that for us, training the young is very challenging because they have a limited exposure to cases.
And we recently had a great conversation on the show about workforce issues in the United States, where we actually have a shortage of doctors in many regions, and it's projected to even have a shortage of neurosurgeons in some parts of our country in the next 5 or 10 years. And whenever I speak with people about the residency work restriction issues, and one of the ways of getting around the hour restriction is, as you say, having more residents, then the knock-on effect of that is a concern that down the road you may have too many surgeons and more than a given population can support. Is that something that you've seen happen anywhere in Europe yet, or are you anticipating that as a worry in the coming 10, 20 years?
Yes, that's gonna be a very, very big issue in the future.
Hmm.
Even now we can already tell, but we are forced to train too many surgeons also because the residents are rather cheap labor compared
We're
um,
too.
faculty or attendings, obviously. And because of that, also the hospitals tend to not mind employing more, and we don't have a regulated system in most countries. So we are kind of forced to train too much, and at the end they tend to go maybe into private practice, only doing spine. Not that I dislike people going into private practice and only doing spine, but if you have a lot of spine surgeons out there in private practice, you will have higher rates of surgery. Very simple. And this has already been a problem, and we are very, very worried this will be even a bigger problem in the years to come.
Yeah, it's such a complicated and interesting topic, and you wear at least two hats. One is professor in Innsbruck, and of course now EANS president, which is president of, I'm assuming it's the EU, or is it just continental Europe?
It's continental Europe, as
Okay.
it's not only EU.
Okay. Yeah, so the interesting thing about it is like when I'm talking to patients, I always start to rant a bit and I'm like, you guys beat up the American healthcare system because people always complain, right? I'm like, you don't understand, America's like all of Europe. So like they want to point out like you said, Austria works pretty well, right? So does Norway maybe, but then they don't factor in Albania, right? Or and so I'm like, America's this giant country. It's about the size of Europe in population or land mass, and it has a similar diversity. Where, for example, like our licensures by state, of the 50 states your license is in, that I can't go to another state and just practice medicine unless I have a license. But in America, it's relatively fluid. We have a very neurosurgery, in a way, is a very, very difficult training program. And then at the end, everybody can do whatever the hell they want, kind of. I hate to even say it like that if patients listen, but there's nobody that can tell you, like, you can't do this or that. But my sense of it is that in Europe, you have a much finer control, like you said. Even after people finish, unless they're in like some tiny little hospital, you have a handle on your trainees for a period of time, or you could extend their training, or there's different ways to do this, right? How do you maybe speak to that, and also how do you deal with crossing borders, right? Is it that someone can go from France to Spain, or someone can go from England to Norway, and they can just open shop and start being a neurosurgeon, or are there regulations in place? How does that all lay out as an EAN as president?
Yeah, well, the you're right. There are differences, and there's a big diversity, much larger than between states within the United States. Because, as you say, Albania, nothing against Albania, great people, but obviously training and their resources may be limited, and some countries may be even worse than that. So that's a huge issue. That diversity within the European Union, you are allowed to change jobs and work anywhere, and your board certification will count. But within the EU, you will have to have proficient knowledge of the language, which is actually sometimes the main barrier. That you have to have a certain level of fluency in the local language, and that hinders most people to change. But obviously, Germans go to Scandinavia, and people really do change quite a bit. But obviously, to get a job, you have to prove that you are good enough. So quite often the best from those countries that you may want to leave, I'm not going to argue about this, are going to go. It's a little bit of a brain drain there, and obviously the systems also work differently in how people are paid. Wages are extremely low, but then they get money aside or whatever. This is sometimes quite difficult to handle and even to appreciate for me as somebody who's living in Central Europe, where everything is very controlled and salaries and everything is very transparent.
I think that's an excellent point, and probably the most important thing when you talk about moving within EU countries, you have to speak the native language, because particularly for us as neurosurgeons, and I would say even more particularly doing spine, I think even using a qualified interpreter, if you're really trying to talk to someone and figure out what's causing their pain, is it real pain, or is it their functional status is low, how much is it causing them disability, and so forth. using an interpreter and lacking not just the having a linguistic barrier, but even having a cultural barrier to understand each other is I think a recipe for disaster. Trying to practice good and honest medicine in a field like this, and so talking about that with these different regional differences moving among the different nations, maybe we can use that to segue into talking about differences in practice between we'll say Europe, and then we can break it down as we talk, and American neurosurgery. And because it's us on the call, we could talk about spine. And
Okay.
maybe to open that conversation, tell us a little bit about your practice at this stage in your career. At the course, you were giving us lectures on the big surgeries, on the corpectomies and stuff, but describe for us what your daily routine practice is actually like now as chair or professor of spine neurosurgery.
Well, actually, I'm still a general neurosurgeon, probably doing almost half and half. So I still do a lot of brain and a lot of vascular cases because my mentor and boss was a cerebrovascular surgeon. So that's where I was trained in, like Peter Vicozzi, we were trained together.
Yeah.
And then but I he told me in 1999 or something that spine is the future of neurosurgery. And so he sent me to Jürgen Harms to get training in complex spine a long time ago. So my practice now is that I would do, since I'm the chairman, you also are kind of forced to do a lot of private patients. I would even do regular spinal stenosis, MIS decompressions, MIS TLIF, you name it, and then would most of the time assist if necessary or train my team in doing complex deformities. So we do a lot of metastasis, tumors. We
Mhm.
try not to do too much juvenile deformity. So that's something that mostly we try to not do too many cases. We do a lot of adult deformity, and obviously the regular C-spine cases, etc., etc. So it's a quite busy practice for European standards. We do about 1,700 spines a year, and so the whole variety of cases basically. And I personally actually am still involved with doing very simple everyday cases for private patients and complex cases for if there are complex patients coming in.
Yeah, it always impressed me, Claudius, because in the U.S. there's been a trend towards sub specialization. Like I don't do anything outside of spine surgery on purpose, so I can focus entirely on being the expert in spine. And the same would go for my functional colleagues who don't do any aneurysms or spine or trauma or anything like that. And it's in Europe, the professor, right? You are, and just to clarify for those who don't know, sometimes words have multiple meanings. I believe, tell me if I'm misspeaking, but in Europe, the professor, there's only one of them. In other words, at University of Miami, we have 7 full professors, only one's the chairman. But in continental Europe, the professor is the chairman, right? That's the boss, right?
Well, it depends on the country. Some countries actually have a research professor and a kind of clinical professor. The clinical professor is more the chairman, and the research professor is more the one responsible for research and academics. In the German system, that's one person that's responsible for both. You may have a professor for functional and a professor for vascular, whatever, below you, but it still is a very hierarchical system. But to be more precise, actually, we also obviously go clearly towards subspecialization. It's still this old generation, if I may consider myself old, that is kind of still doing general neurosurgery, but this is also changing for the next generation of chairmen coming. That they may have one or two or maybe three. For that they only do one is would be very unusual. So they still would be somewhat general, um, it's a difficult question because, to be honest, on the one hand, subspecialization is obviously helpful in becoming better and perfectionizing what you're doing. On the other hand, I sometimes even wonder, if you have, for example, two fields. Um,
Yeah.
it's I'm sometimes even worried that if you do only one thing, and some people may even do very limited areas of neurosurgery, and then that they actually I even sometimes worry that they get too bored or too it's too much of a routine for them, that at the end they're not even concentrating perfectly on doing it as good as they can, because it's
Yeah.
something, because they do the same thing every day. So I don't even know where the perfect balance is, to be
So
honest.
you bring up exactly the cultural difference between, say, your point and mine, which is that I say, well, there's no way a person who does all these different things could possibly have the depth of understanding that I have in this area. And it may even be, let's say, MIS spine, right? There's no way you can do a meningioma, then an aneurysm, then a DBS, and then a trauma, and possibly know, unless you're so much better than me or so much more hardworking or so much more intelligent, right? And so the only people we see as generalists here are the private practitioners who have to do everything for, or they want to, for money, right? So they kind of do everything badly, right? Like I'm not beating on private practice guys, but the brain people would say the same things. Like the skull base people would say, well, you do skull base like 3 cases a year and you think you can do what I do, right? I do 100 acoustics, you do 2. And so in America, it's almost the opposite argument. Now, I'm not alleging that the European argument's wrong. There's something about having an understanding and appreciation of the entire specialty that is a different flavor than what we have nowadays. In fact, there's been trends of chairs in America, for example, for a while it was all vascular people, right? They had all the power. And then now it's all the functional people because they have the NIH grants, right? So all these functional. So the culture of neurosurgery has changed where their body mass index is now smaller, their lean muscle mass is lower, but their IQ or whatever the cerebral, the biases, right? I'm being tongue in cheek here, but you get my point. But let me ask you about this because I think in the recent, certainly with the Trump administration, it's highlighted a lot of the relationships that America and Europe have had in the past, the commonalities, the differences. It's been very interesting because I'm following it very closely. And Europe, of course, is a big place. There's a lot going on there. Our challenges we kind of know about, but give us just a little window. I know you can't do it in just a soundbite, but like, what is continental? Let's call it continental Europe. What are the challenges you're most worried about? In America, we know what our challenges are. What's going on over there in Europe across the pond?
Well, I'm obviously worried about training and enough exposure of the. Sorry, a plane just flying by. All the tourists are coming in to go skiing. We have a big skiing place in the winter. Sorry about that. No, my main worry is that we have too many residents and we are not training them enough, at least this point in time. I'm quite confident that 5, 10 years down the road, with better simulators, we may overcome this. I'm not too pessimistic, but I hope we will be at least getting to a point where they need less real cases and still be quite proficient. And the other problem is money. That medicine is getting more and more expensive everywhere, and even though they are trying to cut down on costs, this is going to be our main problem. And we are not close to being as expensive per case as the United States, because it's a different system. But these are my main worries. The diversity in Europe is getting less. So if you talk to some of the countries, had very, very poor neurosurgical performance 10, 20 years ago. Now this is actually evening out better. So I'm quite happy about that. And one of the issues we should solve is we are allowed to do fellowships, but this is very difficult from country to country. And I think this is something we have to even improve, the exchange between countries within neurosurgery.
Dr. Thomé, we're reaching the end of our time together, and so I want to make sure to get to this question. I'm lucky enough that many of your colleagues at the course actually agreed to come on the show. So we're doing kind of a series talking to neurosurgeons from different areas of Europe. And with each of you, I want to do the compare and contrast America to Europe question, but not in the simplest way, just stereotypes and, oh, what's the difference in spine? America wants to fuse everything, haha. But at least from talking to the different residents from around Europe, the impression that many of them had and what they told me was that spine surgery in Germany and Austria is probably the closest to the American way out of all European nations. And so there's probably a lot more similarities between us on this call than maybe some of your colleagues. But what strikes me the most is that after talking to trainees and surgeons from various different regions of Europe who had very different approaches to the spine problems we saw presented at the course, both in terms of would you even offer surgery or not, what kind of surgery would you instrument, what was futile for traumas, et cetera, et cetera. Um, it seems that there are whole philosophical differences, not just pragmatic differences born of cost and regulation, but neurosurgeons do well in all of these countries, and patients, at least in general, seem to do okay. There may be wait lists, there may be access problems, but by and large, in these different populations with very different approaches, patients are doing well. So maybe if you could give us a high view look at what you think are critical differences in philosophy and approach in different European regions and the US, and which of these differences do you think actually matter versus what might just be appropriate to that culture and that patient population?
Well, I think you're reaching a point that mentality-wise and culture-wise, Americans are more proactive. They surgeons try to solve problems by doing surgery, and there are
Right.
countries, and that's why the Germans and the Austrians and the Swiss are comparable to the States, because we also rather aggressive in performing surgery for trauma, for tumors, for whatever. And also, if somebody comes in with herniated discs, just the general stuff, we tend to be more aggressive with surgery than other countries. Um, at the end, if you look at how their patients are doing, even in countries where you have long waiting lists, it seems like they're not doing that much worse, which sometimes you're surprised.
Mm.
And I think you have to mention, even though you said this is obvious, that we are changing to doing less fusions, much less fusions than we did in the past. 10, 20 years ago, we would also fuse almost everybody. Now we tend to be very, very reluctant to fuse patients, maybe even do some more conservative care, and trying to avoid fusions, because we have all kinds of, obviously, revision cases like you guys, I guess, have as well. And and um, and it's also different from country to country. You have some very conservative countries. I always state that, for example, the Dutch don't operate traumas, don't operate discs, and are very, very reluctant to. But their patients are treated very well overall. They have a very good neurosurgical healthcare system. And we, just neighboring countries, in Germany, for example, almost everybody gets operated, and you don't see huge outcome differences. So there are many ways to skin the cat, I guess. I still believe that with proper indications, being aggressive is a good thing if you are aware of not overdoing it, and not. This is one of the concerns I also, to be honest, have with the states, that if you have a lot of financial incentives, not that we don't have them either, we also have them as well, but financial incentives can be a problem, particularly if you're not that busy.
Mm.
Somebody like Mike, who is super busy, I'm not worried about him doing stupid things or doing indications
I do a
that
lot of stupid stuff, anyways.
no, but you know what I mean. You know what I mean. But with some surgeons that are not busy enough, they do everything, and this is
Mm.
this is this is a this is a problem we are facing.
Well, Professor Tomei, it's wonderful to have you here from Innsbruck, Austria, remotely. Maybe as we close this up, you're the president elect, correct?
Correct. Correct.
So your meeting will be in Basel, Switzerland.
Yes, I'll have two meetings, the one in Basel and the one thereafter, because we have a 2-year term for presidency in the ENS.
Oh, wow.
And so it's actually a 6-year commitment: 2 years elect, 2 years president, 2 years past. But obviously we love our society, and we actually we are most of us are enthusiastic Europeans, to be honest. We love our diversity.
So, quick plug out. This year's meeting is in September to October in Hamburg, a beautiful city in Germany. And I guess Francisco Sala is he's leaving the presidency then, right? And you assume the reins.
No, the year later I will assume the reins. You were right. I will
Oh,
do it in Basel,
okay.
and Francesco is in Hamburg. And for all those listening, come to Hamburg. Hamburg is a fantastic place.
And
End of
your
September.
meetings will be in Basel, Switzerland, amazing, and Krakow, Poland. Wow,
Yes,
we need
that's
to
right.
go. I think JP is going to be going to that meeting.
That's right.
Excellent. Well, thank you for taking the time, and we hope to see you at upcoming meetings and have you back on the podcast again. It's really wonderful, your leadership, what you're doing in continental Europe, and congratulations again on your presidency.
Thank you so much. Thanks so much for having me.